Good afternoon, everyone, and welcome to this webinar. We're so pleased you could join us for today's session. As today marks the start of Self-Care Week, an annual campaign which aims to promote physical and mental well-being. This webinar has been organised as part of a regional programme of activities exploring women's health. During October, we ran 4 webinars which focused on menopause. The recordings of these webinars, along with today's webinar, will be made available by the end of the month. And these sessions have been made possible thanks to the incredible cooperation of library services across the northwest of England. We'd love to encourage you to make the most of your local library, whether it's for health information, community support, or simply a quiet place to reflect. Your library is the place for you. I'd like to give a huge thank you to Libraries Connected, whose generous funding has made these sessions possible. Their support has allowed us to bring expert voices and valuable insights directly to you. In today's session, we will be exploring pelvic health. Aneleigh has been a physiotherapist for 21 years, with almost 20 of those years spent working in pelvic health. Whilst her current role as clinical service lead for the Lancashire and South Cumbria Perinatal Pelvic Health Service involves supporting women and birthing people during pregnancy and their first postnatal year, she is passionate about educating people on the importance of good pelvic health throughout their lifespan. It may seem a bit unusual to start Self-Care Week with pelvic health. However, it is such an important part of self-care. Pelvic health issues may be physical, but they can have a huge impact on your emotional well-being if not managed effectively. We are definitely starting to talk about pelvic health much more than we used to, yet it still remains a topic surrounded by stigma and embarrassment. Hopefully, today's talk will help some give insight into common conditions and create awareness around what we can do to support good pelvic health as part of our self-care routines. And now I'll hand over to Aneleigh to start the presentation.
Thanks, John. Good afternoon, everybody. It's a pleasure to be here with you this afternoon to talk about all things pelvic health. Like John says, today we're going to touch on some of those common conditions and some of the common myths that we have surrounding pelvic health still, even in 2025. We're going to look at our pelvic floor and try and understand that a little bit more, as well as understanding normal in terms of our bladder and bowel function. We're going to talk about pelvic floor exercises, how important they are, how you can get the most from them, and other advice that really will help to support good pelvic health. And then most importantly, it's identifying places that you can go to for support should you need it. So I just wanted to start with a few of the common myths that we hear, definitely as physiotherapists out in practice. So things like holding in a wee is dangerous. It's not, you know, we should be going to the toilet every few hours. We'll talk a little bit more around that later on, but, you know, it isn't dangerous to hold for a period of time. We might find that it's quite difficult to do if we don't do it often enough. And unless we have an infection where it might feel very uncomfortable, there is absolutely nothing dangerous about holding on to a wee for a few hours. People quite often think that you can only, you know, if you only have problems with your pelvic floor, you only need to look after your pelvic floor if you've been pregnant and had children. But that's really not the case, because it should be looked after from birth all the way through our life. We have so many people that assume that it is normal to have a bit of a leak when they cough or they sneeze after they've had children, but it's not normal. In the same way that it's not normal for sex to be painful as we get older, and we need to find ways and means to address that if that's an issue for us. And then lastly, looking at constipation. Constipation is one of the biggest challenges we face within pelvic health, and it is definitely not normal if we are constipated, and it is not okay. So here are some of the common problems that people with pelvic health problems will experience. So we may have incontinence and leaking. We may find that we have to rush to get to the toilet, or we're going quite frequently. We may find that we're getting up through the night. It may be that it's difficult to pass a wee or to pass a poo. And some people may find that they have to physically put pads on so that they've got the confidence to be able to get out and about, because the issues are quite bad for them. Again, we talked about painful intercourse and how that can really impact on our relationships and our day-to-day lives. For some people, they just can't locate, they can't feel their pelvic floor. So we can say to them, you know, do pelvic floor exercises, that will help, but they can really struggle to do so. I think, though, the most important thing that I want to get across from today's presentation is that, yes, these are common problems, but they're not normal. They're not something that should be dismissed. They're not something that should be seen as part and parcel of getting older or having had children. They are common problems, but they are not normal. So how common are these pelvic floor problems that we may experience? So 1 in 3 women and birthing people will struggle with urinary incontinence. 1 in 10 will struggle with anal incontinence. So that could be problems controlling wind, it could be problems controlling stools. And 1 in 12 will suffer with pelvic organ prolapse. So just to give this a little bit of context, across the Northwest, we have a population of around about 7.5 million, and there are about 52% of that population is female, according to the last census that we had. That means that 1.2 million women in the Northwest are experiencing urinary incontinence. 360,000 are struggling with anal incontinence, and 300,000 are struggling with prolapse symptoms. So again, just to kind of give you a bit of a visualization around what that might look like, let's think of Old Trafford. And apologies to anybody who isn't a football fan or a Man United fan, but this is our biggest sporting stadium in the Northwest. So how many Old Traffords could we fill with people who have these issues? Well, 16 for urinary incontinence, 5 for anal incontinence, and 4 for prolapse. So as you can see, it is a significant problem, really, really common. And just think of how many people are struggling physically and emotionally because of these symptoms. But there's good news. And that good news is that most pelvic floor issues are preventable if we start early enough, or if we start to develop symptoms, we can manage them really effectively. So we talk about our pelvic floor quite a lot. What is the pelvic floor? And here we've got those sideways views of both a male and a female pelvis. So your pelvic floor has 4 different functions. Firstly, it's about stability. So you may have heard of the term core stability, which is about supporting our back, our pelvis, our hips, and our abdominal organs. So our pelvic floor is the basin of the pelvis, and it's helping to keep those structures nice and stable. It's also about support. So our bladder, our bowel, and our womb, if we've got one. So it's about being able to keep them nicely supported and up in a good position so that we don't start to feel the effects of gravity and activity pulling down, because that can cause some back pain because of where the joints attach. It can also make us feel really heavy and uncomfortable down below. And it can also lead to issues around urgency and frequency, both from a bladder and bowel point of view. The third thing it does is it controls our sphincters down below. So we should be able to keep our urethral sphincter and our anal sphincters nice and closed until we are at a convenient time to go to the toilet. And if we don't have good sphincter control, we will get leakage. So it's really important that it's working continuously during the day, but also when that pelvic floor is put under pressure. So things like coughing, sneezing, laughing, running, jumping, lifting, anything where that pressure is going to come down onto those muscles. And then finally, it's about sexual function. So it's how we feel and how we experience that sexual experience, making it more enjoyable for ourselves and our partner. So pelvic floor issues, like we said, can affect all genders all the way through the lifespan. But from a women's health point of view, these tend to be some of the biggest factors that influence our pelvic floor. Pregnancy and childbirth, are the biggest ones. But it's really worth bearing in mind the fact that you don't have to deliver vaginally to have pelvic floor problems, because actually the effects of carrying your baby during your pregnancy will stretch and will weaken your pelvic floor, and can still lead to some issues during the pregnancy and postnatally that, if we don't address at that point in time, could stay with us through the rest of our lives. We think very much around menopause and how, lots of changes occur then, but we need to remember that our hormones will affect us all the way through our reproductive life. And we might well find that actually at certain points within our menstrual cycle, our pelvic floor feels weaker than at others. So particularly in that second part of our cycle, after we've ovulated and in preparation for our period, as our hormonal changes happen, we can feel that our pelvic floor doesn't feel as strong and supportive as we want it to. Medical conditions and medications are another thing to consider. So things like diabetes, respiratory conditions, neurological conditions can all impact on the function of the pelvic floor, and subsequently medications that we take to deal with those conditions. Some of them will cause us to go to the toilet more frequently. Pelvic surgery, so from a gynecological point of view, things like hysterectomies, or if we have a fall and we fracture our pelvis and we have to have orthopedic surgery, those sorts of things can impact on that pelvic floor too. Smoking is another big factor. It's not just about the coughing that we might do in association with smoking. It's the irritants within the chemicals that can really affect our bladder and our bowel and make us go to the toilet more frequently. And we can also find that with smoking, the quality of our tissues isn't as good as it could be. So again, the plumpness of our pelvic floor isn't as good with smoking as it is without. And then finally, weight, exercise, sleep and mood, things that we call the 4 pillars of health, which we're going to touch on later in this presentation, can all be factors for consideration. So how do our bladder and bowels work? So we're going to start with the bladder to begin with. Quite often when we see a diagram of a bladder, we think it looks like it's a solid structure that fills up, but it's actually more like a balloon. And from the ureters, so where we can see those downwards arrows coming into the bladder, we have this constant fill of urine day and night. So our bladder is constantly starting to accommodate more and more. And like a balloon, it will start to get bigger and bigger. What should happen is we get to a point, it's normally around about 200, 250 millilitres of fluid, that we start to feel the stretch on that bladder. And it's giving us that first feeling like, I could go to the toilet now. For most people, we should be able to recognise that feeling, but we should be able to defer it. And we should be able to hold around about 400 to 600 millilitres in total until we feel like, yeah, I really do need to go to the toilet now. What can happen though sometimes is that we can get false messages coming down. So the bladder can only be partially full and the brain is telling it to contract, that it really needs to go, and in a condition that we call overactive bladder that you might have heard of before. And with that, if we're going to the toilet frequently because we feel like we need to go, that capacity reduces, because the bladder is muscular. If it's not stretched, we won't get that feeling that we need to go. But similarly, if we can encourage it to stretch and accommodate more, there is potential to be able to hold greater volumes as time goes on. From a bowel perspective, we have 2 different systems. So we have our gastroenterology system, which is about digestion and physically making our poo. And then we have our colorectal system, which is more around the mechanics of being able to get things out. Some people will find that their gastro system, so the actual making and processing, is slower than other people. So it's something that we call slow transit constipation, means it doesn't move through in the same kind of speed that other people's would. But for other people, the transit is good, so the moving of everything through the system is good. But if we don't go to the toilet when we feel like we need to, and we keep putting it off, it may then have a knock-on slowing down effect. So if we're getting to the end point and the gastro system's being told, no, it's not going anywhere from here, it may well slow itself down. So it's really important that when we do need to go, we go. So what is normal? From a bladder perspective, it's roughly every 2 to 3 hours during the daytime. At night time, it will vary depending roughly on age, and this is quite a lot to do with our hormone profile. So before our 50s, because of the hormone levels that we have within our system, usually we should be able to go through the night. We might find that from a female perspective, as we're approaching a period, we may get up more frequently, or if we've had quite a lot to drink later in the evening, or we've drunk particular types of fluid, we might need to get up, but that should be an exception. But as those hormonal changes start to happen in perimenopause and then through into full menopause, we may see once or twice becoming quite normal, which some people are quite happy with. For other people, it can feel quite disruptive. If we're going to the toilet more than that through the night, though, that isn't considered to be normal. From a bowel perspective, we're looking at anything from like 2 to 3 times in a day to 2 to 3 times in a week, and everybody will be really, really different. We tend to be aiming for what we call a type 3 stool, so that one that looks more like a sausage or a snake. If we have issues with our pelvic floor, it's probably better to be more of a type 3 because there's a bit more of a texture there, and it's more for our pelvic floor to be able to hold on to. But if we're going more towards type 1, that's indicating that we're constipated. So when we're getting the rabbit dropping kind of poos coming through. However, if we go down to the bottom through to type 7, that's more your diarrhea, which is really difficult for our pelvic floor to control. So if we don't have a good seal, or if we can't get a good squeeze when an urge comes on, there is the risk that potentially we may have issues with incontinence or soiling. Things that the bowel movement shouldn't be painful. It shouldn't feel difficult. We shouldn't be forcing it. We shouldn't be seeing any bleeding. And if we do, we need to mention that to our GP. It could be something as simple as some hemorrhoids internally or externally that needs some treatment. But it's always worth, whenever there's any bleeding, that we go to our GP. Like I said, we shouldn't put it off. If we need to go, we need to go. And it shouldn't feel like it's out of your control. Moving on to incontinence then, we're going to cover the different types of incontinence just to be able to differentiate between them. So first of all, we have stress incontinence, and that's not about being under stress. That's about stress being applied to your pelvic floor muscles. So when the pressure in your abdominal area is coming down onto those muscles, they need to be able to react quickly to close off your openings so that we don't have any leakage. Urge incontinence is when we get this overwhelming urge that we need to go to the toilet. We can't hold on. And for some people, it may be that they manage to get themselves to a toilet and then they may start to dribble. For other people, that urge happens and it's just coming straight away and there's nothing they can do about it. It can be really, really distressing. And it's one of the main reasons why people become socially isolated, because they are really worried about being out and about and not being able to access a toilet. Anal incontinence covers wind, which obviously is the finest of the things that we need to control, but also liquid and formed poo. So like I said on the previous slide, your pelvic floor has to work harder to contain wind and liquid than it does to keep a formed stool inside. Mixed incontinence is when we've got 2 or more of these 3 happening at the same time. And in my experience, and probably that of other pelvic health physios, you tend to find that one problem is more distressing than the other for those who suffer with it. And then lastly, we've got overflow incontinence, where we're getting to the point where we're feeling too much. So we've spoken before about not feeling enough, but for some people who have neurological conditions, they may not feel that their bladder is at capacity, and then what's coming in has to go out at the other end. Pelvic organ prolapse is really common within women, and these images here just show you what the anatomy should look like. So your normal anatomy there on the left-hand side. A cystocele is when your front vaginal wall has weakened and starts to give. Okay, so with any kind of prolapse, it can be a little bit like a two-way door. So if the vaginal wall is coming inwards into the vagina, it can then feel quite uncomfortable and you can be very aware of what's going on. But similarly, it could also push the opposite way and cause a bit of an obstruction when we're trying to pass urine. A rectocele is the same, but from a back wall perspective. So again, you could feel that and you could see that in the vagina itself, or you could find that it's causing obstruction and difficulty when we're opening our bowels. A uterine prolapse is when the womb isn't being supported and held up in the way that it should do, and it's starting to drop into the vagina itself. So these are the sorts of symptoms that will get a heavy dragging, pulling sensation, either down below or particularly into the back and pelvis, those two joints on the back of the pelvis. A lot of people will feel like there's a feeling of fullness or bulging inside the vagina itself. So like they can't get comfortable, or people will say, you know, it feels like there's a golf ball there or something, or a bit like you've got a tampon in that's too absorbent for your flow. And like I said, it could lead to difficulty with being able to empty, a bit like, you know, if you're thinking about a hose pipe, if you've put a kink into that hose pipe, it will stop, the flow will stop. But you might then find as you stand up and you release that some urine comes gushing out, something that we call a post-micturition dribble. That is really quite common. You might find that it causes a physical obstruction for being able to empty the bowels effectively as well, which is really quite distressing for people. Mentioned as well that we can get some soiling, we can get some leaking, or we might find that we're having to really wipe clean to be able to get ourselves feeling like we've sorted ourselves out after a bowel movement. And that's because sometimes we can leave, if we've got a little pocket or a little bulge where the stool can sit in, your body's natural reaction is to clean itself. So it might produce a bit more mucus, which then starts to seep out, and it can be really quite distressing for people. And they can feel like, no, they've wiped themselves clean, but then they go back to the toilet a few hours later to have a wee, and there'll still be something coming out. That's very typical with pelvic organ prolapse. And then lastly, you know, there's pain or difficulty with having sex, or even just the feeling that we don't want to because of what's there. Just to reassure you that it isn't going to cause you any harm at all. It's probably more uncomfortable with a womb prolapse because the cervix is a harder end feel to it, so it can be more uncomfortable. But your cystoceles, your rectoceles, your front and back vaginal walls are soft tissue. They will move out of the way, and it's just that reassurance that you won't be causing yourself any harm. Sexual dysfunction is part and parcel of what we treat as pelvic health physiotherapists. It may be that it's something that comes on all of a sudden. It may be something that builds up gradually over time. It may be something that's linked to trauma. So if we have a difficult birth, or if, you know, we have an accident, it may be sadly linked to sexual abuse. But, you know, it is really common for us to see this, as are the hormonal changes. You know, like we said, particularly in the menopause or at certain stages within perimenopause and our reproductive years, we may find that it's quite uncomfortable. We may find that we don't have the desire. We may find that it's difficult to orgasm, and we may find that it's painful. And obviously, if it is painful, either deep within or on the outside, that's going to affect both our desire and our ability to orgasm. We've obviously had a series of talks specifically around menopause, and just wanted to recap on these in relation to the pelvic floor. So there is actually, you know, it is recognised now, we are talking about it more, that genitourinary syndrome in menopause, so GSM, is really common. And when you look at the studies, they're saying anything from 27 to 84% of women. That's quite a range, but I think that's because it's still really underreported. And these are the sorts of things that we'll see reported around itching, dryness, things feeling uncomfortable, the tissues being thinner and like feeling like they might crack, feeling like we've got more infections. So there could be more physical infections, but it could be that the lack of hormone in that area is mimicking those sorts of symptoms. So some people will go to their GP, they'll have a urine sample taken and they'll say there's no infection there, but we've still got the same sorts of symptoms. We may just feel more sensitive. We may be prone to more of those pelvic floor problems that we've spoken about already. But it's just to reiterate that absolutely in perimenopause and menopause itself, these symptoms are really common and we need to be doing something about it to improve our quality of life and really help ourselves look after ourselves. In terms of how we can manage it, for some people it is just about keeping things, well lubricated. So a vaginal moisturizer may be enough, and you can get these on prescription, but you can get them over the counter as well. So things like Yes VM is a really good one. Silk is another. Just something like in the same way that we would, moisturize our face, we would do the same with our vaginal tissues. We may also want to do a bit of massage and a bit of stretching to keep those tissues nice and mobile and nice and supple. But it may be that the hormone is what we need. And so a discussion with your GP or with a practice nurse who has a specialist interest within menopause is definitely the way to go here to see if it's appropriate for you to proceed with hormone replacement therapy or HRT. And then lastly, pelvic floor exercises. If we can exercise those muscles and get, good bulk and good strength into them, it can help to reduce some of these symptoms quite significantly. And your pelvic floor absolutely is key to good pelvic health throughout the lifespan. So 60 to 70% of pelvic health issues can be managed effectively with pelvic floor exercises. However, nearly 1 in 4 women have never done pelvic floor exercises, and 1 in 4 women can't perform pelvic floor exercises correctly. So, a quarter of us either don't do them or can't do them. And this is where it, recognizing how important it is, particularly if we're in that 1 in 4 who haven't done them but can, really recognizing that we're in a position here to manage things really effectively for ourselves. So there's 4 key things with pelvic floor training that we need to consider. So first of all, we need to have a good technique. So it's a feeling as if we're trying to stop ourselves passing wind. So the pelvic floor loops round your 3 openings down below. So round the back passage, round the vaginal opening, and round at the front where we pass water. The research tells us if we start at the back as if we're trying to stop ourselves passing wind and bring that squeeze forward, so we should feel this squeeze and lift, that is the most effective way to do that. So technique is really, really important. We need to consider the types of muscles that we're working on. So within our pelvic floor, we have 2 different types of muscles. We've got slow muscle and we've got fast muscle. We have more of our slow muscle because that is the supporting stuff. That has to be working continuously throughout the day to support those organs, to support the joints in the pelvis. And it needs to be able to deal with the weight of the organs on it. It also needs to be able to deal with the weight of gravity growing through it and also the weight of any activities that we put through it as well. So those slow muscles really have to have loads of stamina and loads of strength to deal with our day-to-day activities. Our fast muscles aren't working all the time. They just have to be able to kick in quickly when we do things that increase that tummy pressure. So things like coughing, sneezing, laughing, lifting. It's about that sharpness and speed of reaction to be able to stop us from leaking. So I tend to think of them a bit like runners. So your slow ones are like your Mo Farahs, your long distance runners that need to keep going and going, whereas your fast ones are your Usain Bolts that need to be very, very quick. So, both runners, both using the legs, but in different ways. We have to make sure that the pelvic floor exercises are challenging enough, because it is training at the end of the day. If we are doing exercises and we don't feel like we're getting better, it could be that we're just not pushing those muscles enough. So there are different ways that we can challenge that pelvic floor. The first one is around thinking about our position. So they're easiest to do when we're lying down, because we have very little in the way of pressure going through those muscles. When we're in sitting, we've got a little bit of resistance to work against, because we've got the weight of those muscles there resting down on the pelvic floor. And sometimes people will feel like, it's better to do it in sitting because they've got a sense of what they're meant to be lifting. But for some people, that might be too much. So lying down is a good starting point. Ideally, though, we want to be working up to doing these exercises in standing, because the vast majority of problems arise when we are in a standing position. So when we are picking something up, when we are trying to get ourselves to the toilet. So it's about challenging those muscles to be able to deal with the situation that we are in when we have our issues. So it's really important that we do challenge those muscles. From a slow muscle point of view, it's about making sure we keep building up that length of hold as much as we possibly can. So you will read information around how to do it. It will say, do a 10-second hold 10 times, 3 times a day. That's great if people can get to 10 seconds, but for some people, they might find that they maybe only get to 2 or 3, and they can start to feel that the muscles are tiring already. So there's no much benefit to them trying to hold on any longer. But what they should do is find that length of hold that when we are doing, maybe our 8th, 9th, 10th rep in a set, that it feels challenging. We feel like we're working hard. And that once it starts to become easier, we gradually build up that length of hold to make things more difficult for us. Once we're managing to do exercises in standing, it's again thinking about how can we use those pelvic floor exercises during activity to support us even further. So challenge is really, really important. And then lastly, frequency. How often we do them is key. So if we have issues with our pelvic floor, the guidance that's out there is saying that we should be doing 3 sets, each one with a minimum of 6 repetitions in it. So ideally between 6 and 10 repetitions per set. We should do 3 sets every day. So 3 sets of slow holds where we're working on our support and our stamina, followed by 3 sets of quick squeezes. So pulling in quickly, letting go. Quick squeeze, let go. And it's really important that we relax fully in between each of these exercises, because if we don't, we find that we're tightening and tightening and tightening. We're not letting go, and we need to be able to do that. So different exercises for different things. So slow exercises for support, for stamina, for urge, frequency, prolapse type of symptoms. And then those fast exercises, particularly for stress type of symptoms, so the coughs, the sneezes, and the laughing, etc. Quite often we find if people feel that pelvic floor exercises aren't working for them, they've either not been doing the right type to address the symptoms that they've got, they haven't been challenging themselves enough, or they haven't been doing it often enough to make a difference. And remember, with any kind of training, it takes months to get to where we need to be, so we don't give up after a month thinking that it hasn't worked. It's more than likely going to take us around about 3 months to really see those big changes. Other things to consider then, so our weight is a big one. Research suggests that even a 10% weight reduction could improve symptoms by up to 50%. Again, we need to think about smoking and the impact that that would have there. So if you are a smoker, talking to your GP or your practice nurse around smoking cessation support, because that can really, really make a difference. Thinking about the fluids that we drink. So the type of fluid, first of all, is really important. So for some people, things that are caffeinated can really make a difference. It can really irritate our bladder if we have urgency. So reducing or eliminating caffeine from our fluids can make a big difference. Other things that can irritate include fizzy drinks, alcoholic drinks. things that have got artificial sweeteners in. So we go, maybe if we're going for something like a diet version of a drink, more likely to have artificial sweetener and more likely to be an irritant. And then lastly, anything that's quite citrusy can all make our bladder and our bowel a bit more irritable. On the flip side, it's looking at our volume, because quite often people who have issues with leakage or urgency will restrict their fluids because they don't want to have to go to the toilet frequently, so they won't be drinking enough. What will happen with that is that we find that the urine that we do produce is much more concentrated, and it's more of an irritant to the lining of your bladder. So we think we're doing the right thing by keeping the volume low. In actual fact, it's potentially making the situation worse. So we should be drinking 1.5 to 2 litres of fluid per day, ideally not caffeinated, not fizzy, not citrusy, and not alcoholic. Thinking about our diet, so that can affect both our bladder and our bowels. We need to be eating plenty of fruit, veg, and nuts and seeds to really look after our bowel. So I mentioned before around constipation being an issue, but if we eat, good amount of soluble fibre, because we think about fibre, we tend to think things like bread, cereals, pasta. They're not the sorts of fibre we need. We need the fibre that's in our fruit, our veg, and our nuts and our seeds. Something that's particularly good that we've seen really good positive effects from is ground linseeds or flax seeds, which you can get in your supermarkets already ground down. A dessert spoon of those on like porridge or in some yogurt, something that's wet that helps it to be absorbed into the gut quite nicely, can really, really have a big difference. And I personally have seen people struggle with constipation for years and years, perhaps have been on laxatives for a long time and have made that switch over to linseeds and changes to the diet, and it can really make a huge difference, and they don't need to take the medication anymore, or not as often. And it's thinking about our toileting habits. So making sure that we sit properly on the toilet. So making sure our feet are nicely supported, that we don't hover, because if we hover, our pelvic floor doesn't switch off. It's holding on a little bit. And if we're having issues with not emptying properly, that's just going to make it even worse. From a bowel perspective, if we do struggle with constipation, having a little footstool underneath your feet and leaning yourself forward can put you into a squatting position, which is actually more effective than sitting in an upright position. So little changes like that can really, really help. You might find that if you're going to the toilet really frequently, that doing a bladder diary is helpful. Ideally, you'd want to do it over 3 consecutive days to get a clear picture of what's happening. And it is basically using a measuring jug to see how much you wee out, and also how much do you take in, and how often are you going. Because remember, we were talking about the volumes that our bladder should hold. Sometimes when we do a bladder chart, we'll realise that actually we're going to the toilet more frequently, and those volumes are quite small. So sometimes that can help us with being able to retrain our bladder as time goes on. We mentioned about coughing and how that can have an impact. So if you are somebody that struggles with a respiratory condition, as you're coughing, tightening your pelvic floor before you cough so that it's braced and it's ready for the pressure that's going to come down onto it can help to reduce the leak, or hopefully stop that leak from happening altogether. We want people to be able to exercise, and actually pelvic health issues, 1 in 2 women will stop exercising because of their pelvic health conditions, not because of other things. So it's thinking about the type of exercise that we do. We absolutely want people to be doing exercise as we get older, particularly strength work, even if that's body weight, and some cardiovascular work, because we know when we're in the menopause and postmenopausally, we can struggle with bone density. We could, if our balance goes and we fall, we can have some issues there around fracture. So we absolutely want people to continue with doing exercise, but we probably just need to think about the type of exercise that we're doing. So if somebody is a runner and they're finding that they're leaking, it's telling you at that point in time your pelvic floor cannot deal with that pressure that's going through. So either we have to scale it back to more of a fast-paced walk whilst we retrain our pelvic floor, or we need to consider other options for that period of time. But I would definitely say never with these things. It's really, it can be really soul destroying for people who want to be able to do things. It's just a not right now. Same with strength training, because the research shows there's so much benefit to us doing weight training, but anything that makes us feel like we're heavy down below, or anything that makes us leak, or anything that makes us feel vulnerable in any way, like we could leak, is telling you that that exercise isn't right for you right now, but that doesn't mean that it won't be in the future. Oh, my slides have just gone. Sorry. We'll just see if I can go back in. I don't know what's happened there. Apologies. Goodness.
Let me know if you can't get them up. I can try them and bring them up from my side if you like.
Yeah, sorry about that, people. Don't know what happened. So we were at slide 21, I think. Let's see. Huge apologies. Can we see that now?
Not yet. You'll need to. I think you'll need to share your screen again.
Yeah, sorry about that. Okay. There we go.
Yeah, that's right.
Perfect. So, in terms of other things to consider then, so we've talked about HRT, potentially around medications. Some people, they don't actually need that. They just need a little bit of topical estrogen. So a little bit of each estrogen cream, either just inside the vagina itself, so within that first third of the vaginal opening, because that's where all the receptors are, or around the urethra. And sometimes that can be enough just to help with some of the symptoms that we may have. And then it's sort of like knowing when to ask for help, because if you're doing all of these things and you're finding that you're doing the exercises, you're eating well, things like that, and we're still struggling after 3 months, then potentially we do need to be referred on somewhere else. So it's going to your GP or your practice nurse, or you may even be able to refer yourself to physiotherapy, but it's always worth making contact and getting yourself some support at that point in time, and not just thinking, this is part and parcel of life for me now. I mentioned before around 4 pillars of health. So the 4 pillars of health are nutrition, so making sure we're eating well, making sure that we're doing the right things to keep our system generally happy. Because sometimes when we're a bit fed up, if we've got these issues going on, we might want to give ourselves a treat, but actually that may increase kind of inflammation within our system. And if we have issues with irritation within our bladder or our bowel, sometimes that can make things worse. Movement is really important, and like I said, we've alluded to that on that previous slide, that all movement is good. I always say movement is medicine, because even just going out for a walk or doing a Pilates class, something that's quite low intensity, can really make a difference. And if we're feeling better in our headspace, looking after our mental health as well as our physical health, it can have a good impact on our bladder and bowels as we're re-educating them. Sleep is really important, and sometimes that's easier said than done, but good restful sleep means that our muscles are rested ahead of the next day. Sometimes we might find that there's other reasons why we wake. It's not necessarily our bladder that's waking us up or our bowel that's waking us up. There may be other things, there may be pain, etc. But sleep, if we can get it, is really, really important. As is your mindfulness and your mood and your relaxation. So having a bit of time every day just to kind of do some good deep breathing exercises, because your pelvic floor works in conjunction with your diaphragm, which is your breathing muscle, can really, really make a difference to how we are experiencing our symptoms. Just wanted to signpost you to some really useful resources. So this webpage for the Pelvic Obstetric and Gynecological Physiotherapy is a charity, basically, who have loads of resources that cover the whole of the lifespan, and they're available for free. So you can go onto the web page, go into the booklet section, and there's a whole raft of different leaflets that you could potentially download. The good thing about this website is that it's got the recite me function, so it can translate it into different languages. So there's over 100 different languages on there. Some of them also have an audio option. So if somebody, is struggling to read, or is partially sighted, or can't read, there's the opportunity there for them to hear the advice as well. You can change the background colours, for those who are neurodiverse. You can change the font size, etc. So font size, sorry. So there's lots that we can get from this particular website. And then obviously this is around our libraries and support. So these are just a few of the books that the Northwest POGP group recommend to patients that we're working with. And they cover a real variety of topics, all linking in with pelvic health. But it is good to, these are credible and reputable sources that if you were thinking of where can I go for a bit more support, this is where you can go. So my top 3 takeaways. So number 1, pelvic health and pelvic floor problems, common, not normal. Don't accept that it is normal. Remember that in most cases, we can prevent or we can effectively manage pelvic health conditions, and know that support is there. So there's loads of resources out there to support you. If you've tried everything for 3 months and it's not getting any better, please don't suffer in silence. Please go and get some support. So thank you very much.
And thank you, Aneleigh, for being here today. And what an informative session I think that was. I'd like to thank everybody who tuned in today. The video of this session will be made available shortly. Thank you all for being here, and have a wonderful rest of your day.
Thank you.